بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد عليه أفضل الصلاة وأتم التسليم. Distinguished colleagues, ladies and gentlemen, first of all I would like to thank the scientific committee, particularly my great friends Dr. Mahmoud Amber and Dr. Sami, for giving me this opportunity to participate in this outstanding conference and to present our research project titled Improving Quality of Life for Ambulatory Patients with Advanced Lung Cancer through Phone Triaging. That research project is really just published in Gulf Thoracic Annals on March 2014, and it gets the prize as one of the 3 best research in the cancer panel on Gulf Thoracic Congress in Dubai, March 2013. At the beginning, palliative care The goal of palliative care is to improve the quality of life of patients and their families who are facing life-threatening illness. How? By early prevention and supporting their complaints, either physical, psychosocial, or spiritual, by means of early identification, assessment, and treatment. That's not easy, since the provision of palliative care to patients with advanced lung cancer who tend to have high levels of symptom distress due to the severity of their physical and psychological symptoms can be challenging. And really, in most of the palliative care departments among the ward and supportive care centers, patients with advanced lung cancer who are outpatients pose additional challenges because of limited follow-up visits, and they have to deal with the complex and time-consuming logistics of ambulatory care. At the same time, members of staffs often waste considerable time and energy in organizational aspects of care that could be better used in direct interaction with patients. So, our study aim and hypothesis was we would like to explore that initiating daily triaging by clinical nurses via phone can help to address the needs of both lung cancer patients and their at-home caregivers. Guys, it's a matter of using art of technology, using that small device in patient's management process. So the design, it is simply quality improving observational study using the Edmonton Symptom Assessment Scale, which is a valid and reliable assessment tool to assist in the assessments of 10 common symptoms experienced by cancer patients. So the setting was outpatients palliative care clinics at supportive care center, Security Forces Hospital, where lung patients receive chemotherapy and complementary palliative care. So the methods: at first clinic visit, a nurse trained in palliative care explains to the 24 patients our sample with advanced lung cancer with mean age 54.6 and the male to female ratio 3:1. And their caregivers to ensure the scale is understood and properly filled out. Symptoms included on the ESAS are pain, fatigue, depression, nausea, anxiety, drowsiness, best appetite, best feeling of well-being, no shortness of breath, and best sleep. So while the Edmonton Symptom Assessment Scale is systematically used with each phone call, the numerical 0 to 10 rating scale is also used to assess current patient distress. The phone triage nurse has access to previous ESAS scores through the patient's medical record to determine the patient's goals for pain control, recent symptom scores, and recent change in medication regimen. So the result shows that the first ESAS consultation revealed a high symptom burden. Initial managements of symptoms focused on shortness of breath, pain, nausea, appetite, anxiety, and sleep. So time from the first consultations to the final clinic visit was 2 months, at which time the mean score of ESAS found that symptom burden has decreased overall. Phone conversations between the palliative care nurses and patients took place between visits and continued after their final visit and until their ultimate decision to transition to hospice care and home care. Because the patient's subjective feeling of shortness of breath increased with disease progression, home oxygen and short-acting opioid therapy were introduced to lessen their distress. Subsequent follow-up phone calls with palliative care nurses noted a decrease in symptom burden and an increased sense of comfort and control with self-managing care at home. That figure showing the ESAS score from initial supportive care center consultation with the pink color and final follow-up visits with the orange color, and we can see clearly that we can see clearly that most of the symptoms was improved except the best appetite with continuous phone calls that the family and the patients can't communicate with the trained nurses. So as a conclusion, the information from the cases included in this study, as well as our experience with other palliative patients regarding the importance and effectiveness of an outpatient palliative care phone triaging staffed by designated nurse is limited. Even our literature review, we cannot find any study except 2 case reports use same methods in Boston. So nevertheless, the results suggest that patients, as well as their family members and at-home caregivers, benefit from having this resource available to discuss questions and concerns regarding symptom management and emotional support throughout their cancer journey. Further studies of the effectiveness such a program are warranted for sure. Thank you so much.